Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network, and I'd like to welcome you all to our RN and Allied Health Lecture on today, November 8th, 2017. A few things to go over before we meet our lecturer. If you have any trouble, the best way to get a hold of us is pick up the phone, 919-445-1000. Give us a call if you're experiencing any technical difficulties, and we'll do everything we can to help you out. You can also email unccn@unc.edu. You can find us on the web at unccn.org. That's the best way to find out about all of our different programs, recordings, etc. And we'll talk more at the end of today's presentation about our new Enduring Materials format, our learning portal. We're very excited about that, and that means that lectures, including this one, can be viewed after the lecture up to a year after today, and you can receive appropriate credit based on the offerings that we have for the lecture. All right, we're on Facebook, we're on Twitter, we're on YouTube, and we'll be using poll everywhere. Let me talk about that next. So we have a poll, and the way you're going to join this poll, there are two ways you can do this. One is you can go ahead and go on the web, including with a smartphone, to Pollev, POLLEV.com/UNCCN. And then as this question and then our Q&A at the end, as those occur, you'll be able to respond right there. Probably more of our attendees actually go ahead and text the letters UNCCN to the number 22333. So the way this works on any device that can text, you text to the number 22333, the letters UNCCN. Only need to do that one time today. You'll receive a little message back saying that you've joined, and then you can respond to this question and later to our Q&A. So our question today, according to 2014 data from the National Hospice and Palliative Care Organization, the largest number of hospice users by primary diagnosis was comprised of cancer patients. So if you believe this is true, you're going to go ahead and send us an A. If you think this is false, send us a B. This is anonymous. This is a way to let you jump in and start using poll everywhere and find out a little bit about what you think. All right, so without further ado, let me shift the camera so that we can include Dr. Winzelberg. Dr. Winzelberg, welcome.
Thank you.
Thanks so much for being here today. Let me tell you a little bit about our speaker today. Dr. Gary Winzelberg is an associate professor in the Division of Geriatric Medicine within the School of Medicine and UNC Chapel Hill. He is board certified in palliative medicine, internal medicine, and geriatric medicine, and serves as the program director of the Hospice and Palliative Medicine Fellowship Program at UNC. Dr. Winzelberg has been the recipient of the Brookdale National Fellowship and a Geriatric Academic Career Award, and was a 2013 Fellow in the American College of Physicians. Dr. Winzelberg's teaching focuses on improving physician end-of-life care, communication skills, particularly with families of incapacitated patients. So, Dr. Winzelberg, maybe you can start by telling us what led to your interest and ultimately a career that is focused on palliative care.
It was actually through experiences I had with vulnerable older adults, elderly patients, way back before the field of palliative medicine existed. So for me, one of the most exciting things about my career has been essentially the creation and subsequent growth, because the work that I currently do did not exist 20 years ago. But it was through geriatrics, which is where many of the kind of current, more senior physicians kind of came from, geriatrics and oncology. For me, it was geriatrics.
So palliative care 20 years ago, did not exist.
Correct.
It's hard to even imagine that, and I'm fortunate to work with and help support from a technical standpoint some of the programs you have, and it's so important. It's hard to imagine that not having been there. With that, wow, we've got a great response to our poll already, so it looks like we're trending on the true here with about 71% and 29% saying no, that is a false statement. We'll wait just a few more seconds in case anyone else would like to respond. Do you want to give away the answer
Well,
now?
actually, it's going to be on one of my slides.
Okay.
Honestly, in some ways, both are true, and I'll explain.
Great. All right. So we're going to leave you in a little bit of suspense here, and then you'll find out more shortly. Without further ado, then, the roles of hospice and palliative care in improving quality of life. Dr. Winzelberg, and take it away from there.
Thank you.
All right. Thank you.
Well, I appreciate sharing this time with you all, and actually, I didn't know this, and I'm sure Tim didn't know, this is National Hospice and Palliative Care Month. And so this topic is obviously at an opportune time. I've got a few kind of background slides. So one is just kind of orienting us a few years ago to what the most common causes of death are in the United States. And clearly heart disease is number one, and then related conditions like stroke. But number two, which is actually increasing as a cause of death between 2000 and 2015, is cancer. And I think that reflects with kind of better treatments for heart disease, there being a little bit of a shift. In palliative medicine, and I mean this next slide a little bit with tongue-in-cheek, we've yet to change the mortality rate. It is 100% year to year. We may think that we can avoid it, but unfortunately not. And then what we think about in hospice and palliative medicine are issues beyond death, and one is symptoms. And so to orient you to this slide, and I realize it's a little bit busy, this is looking at various physical symptoms on the x-axis, one for each symptom, insomnia, appetite, nausea, going on the slide, for both patients with solid tumors and hematologic malignancy. And if you see, and this is going to be a theme, kind of comparing the two kind of subtypes of cancer, there is significant symptom burden. The one that clearly affects the most patients and is challenging to treat is fatigue. So green means no symptom, red is mild, blue is moderate, kind of brown is severe. So there is significant symptom burden really throughout. Fatigue is the most common. And then in terms of performance status or function, and this is in the sort of 190 or so days before death, there's a clear decline in those few months before death. And again, as you see, there's no significant difference between solid tumors and hematologic cancers. And then kind of thinking about what services we provide to patients towards the end of life. This is a study of almost 1,000 patients at MD Anderson. The vast majority, 86%, had solid tumor. But look at what some of the treatments were that these patients received. Chemotherapy, almost a quarter of patients with hematologic malignancies received chemotherapy in their last 2 weeks of life. Targeted therapy, a similar percentage. And then if you look at a combination, it's more than a quarter for heme malignancy and 10% for solid tumor. So, those are patients who I think we would have a consensus aren't, hindsight is 20/20, but aren't going to be served by disease-directed treatments. Why is that happening? And then in a similar vein, again, for these same patients, what kinds of treatments did they receive in the final month of life? Almost a half were in the emergency room. Half or more were hospitalized. Even some had more than one hospitalization, significant risk of ICU admission, and comparing hematologic with solid tumors, both had a significant risk, with hematologic malignancies having even a 50% death rate in the hospital. So real opportunities for kind of changing our culture, changing our care, but what options besides the hospital do patients have? And so my objectives today are review a bit of the history really of both fields, which I think is important to kind of ground when we talk about quality of life and outcomes, how these programs came to be. review some of the nuts and bolts of the clinical components of each discipline and what the relationship is between hospice and palliative care, what some of the barriers are to service delivery, as well as what we know. Fortunately, there's an increasing evidence base for what impact particularly palliative care has on the lives of patients with cancer. So here is Dame Cicely Saunders, who's credited with founding the hospice movement in England and died a little bit more than 10 years ago. She is her own, we focus on interdisciplinary teams in hospice and palliative care. She's her own interdisciplinary team. I didn't actually know this until I prepared this talk. Was a nurse, social worker, and physician all in one. Founded St. Christopher's Hospice in London, which actually opened about 50 years ago. And kind of tracing where things were in the United States, Medicare and Medicaid program started in 1965, then 7 years later, extended coverage to all patients on dialysis. A few years after that, about 10 years following the hospice in London, was the founding of Connecticut Hospice, thought to be the first dedicated hospice in the United States. A few years after that, thinking about living wills and DNR orders. But it wasn't until 1982, really, decades after the advent of Medicare, that the hospice benefit was created. Followed about a decade later by the Patient Self-Determination Act, which requires us to ask patients whether they have advance directives and would like assistance in completing them. So, Medicare, as many have said, is kind of a sickness program, focused on acute care. Hospice came much later after its founding. And this is what we know, and this gets to the question that started. When hospice was founded, and this is data on the left-hand side from 1992, it was essentially an end-of-life care program for patients with cancer. And still to this day, kind of by diagnosis, cancer has the most patients served by hospice. But if you look at the table in 2014, there are more patients who have diagnoses other than cancer being served by hospice. So that's why I said that in some ways both answers are correct. I think hospice was created really with cancer in mind, as I'll share, but has expanded to serve patients with other life-limiting conditions. And the philosophy grounded, that hospice is grounded in, the vision is that it's a service for individuals and families facing serious illness, death, and the grief experiences with the best care that humankind can offer, and is currently our standard of care when it comes to end-of-life care for quality and compassionate service. It is, as I said before, a team approach that includes medical care, symptom management, as well as attending to patients' and family support needs, geared towards the individual. And the way that I describe it to patients and families is to help ensure that they have the support for every day to become the best day possible. And it's really independent of number of days. And as we'll talk about, kind of prognosis can be a barrier to patients receiving hospice services. So this eligibility criteria for Medicare, which I think is followed by most private insurance, is a few things. One is there has to be certification by a physician that the patient has a terminal illness and is expected to live for 6 months or less with the disease taking its usual or normal course. But again, I think in terms of prognostication, it doesn't require people to only live less than 6 months. It's if the disease follows its normal course. I've had, and this was an outlier, but a patient who was appropriate for hospice up until 14 months. And so for that purpose, there are election or certification periods. Initially, it's for 90 days, then it's for another 90 days, and then there are subsequent 60-day periods. So it's not as if people start to receive hospice services and then it lasts for 6 months. periodically the hospice needs to recertify that patient as meeting the criteria. And part of that challenge with prognostication leads to kind of underutilization of hospice services. And this slide, this table shows the very short or long enrollment for patients with hospice, receiving hospice, stratified by cancer and non-cancer. And so very short is less than a week. And I think any person who has practiced in hospice would say it can be exquisitely, extraordinarily challenging to meet patients' needs when the care is less than a week. And then the long hospice enrollment is for more than 6 months. And if you look at 2010, the very short enrollment was about a third of patients in hospice receiving care for less than a week. And the blue is non-cancer, and the red is cancer. So still, again, a substantial number of patients who receive hospice for a period of time where it's hard to meet their needs. The general eligibility guidelines beyond prognostication include the following. One is patients and families have to identify as a priority symptom relief rather than cure or disease treatment, even if it's meant to prolong life, because hospice does not receive funding for disease-directed treatments. Another criteria or eligibility guideline is disease progression, whatever the underlying disease is. And then there are certainly signs of change. I mentioned in one of the initial slides about functional impairment. Well, there's that, dependence in at least 2 activities of daily living, if someone is experiencing weight loss or has a low albumin, and then healthcare utilization, need for frequent hospitalizations or emergency room visits. And so hospice was developed with cancer as the model condition, as I said. And then, again, if this were a different talk, there are criteria that have been developed for other diagnoses to kind of give people a sense of who might be eligible. In terms of the benefits, it includes having a team that are designed, oriented towards supporting patients and families, again, with quality of life as its focus. And so for most people, that means care at home in terms of where they would like to be. Hospice as a benefit, as an insurance benefit, is required to pay for all medications, equipment, and supplies related to the hospice eligible diagnosis. And so that's where if someone has cancer but is receiving chemotherapy, since that's the diagnosis that is related to their receiving hospice services, hospice would be required to pay for it. And that's where there's the challenge of, even if it's meant to be palliative, let's say radiation oncology treatments, there are patients who complete that course before receiving hospice care. And then another important benefit, which I think we sometimes don't pay as much attention to, although we should, is bereavement support for families, which can be offered for up to 12 months after someone's death. And that truly can occur even if someone receives hospice for hours. That bereavement support is provided. So some of the nuts and bolts of what is available for home hospice includes 24-hour on-call responses from a nurse. And what I share with patients is it's a added layer of support, particularly for people who may have symptoms but would prefer not to have to call 911 if they're feeling distress. The nurse visits, and again, really all of the other disciplines can be, the care plan is designed based on the patient's needs and can evolve. The nurse visits can be once a week, can be more depending on someone's needs. Home health aides, and that's another issue for home hospice, generally is limited up to a few hours a day, but I would say for many hospices or individuals it's not even on a daily basis, and that's why family support is required. Social worker, chaplain, volunteers, again, a care plan gets put together and can differ based on the patient. Home hospice, absolutely people can continue to see their own physician if that's helpful for them. And then therapy, it's not as if people can't receive therapy, but it's different than if someone is receiving rehabilitation with certain functional goals. And then this kind of package of benefits clearly depends on individual hospice organizations in terms of what they're able to offer, as well as what patients' needs and preferences are. Inpatient hospice, as I'll show in a later slide, is increasing as an option, small but increasing. And it exists for patients who have pain and symptoms that can't be effectively managed in the home or another setting, let's say long-term care. And that really, Medicare kind of pays attention to that in terms of does someone have those needs that can't otherwise be met? And that can include, again, skilled nursing care, intensive nursing as I would call it, on a 24-hour basis to maintain comfort, to address those symptoms. It's meant to be a short-term intervention, although there's no specific number of days or episodes. I recently was part of a care of a patient in inpatient hospice who received care there for a couple of months based on significant disease burden, pain that was really evolving, not necessarily day to day, but each week. And inpatient hospice in general has all of its costs covered by insurance. Then there are other hospice services that I certainly want patients and families to be aware of. One is respite, so kind of per billing period. And I sometimes forget exactly whether that's a certification period or per month. It's up to 5 days. And so if someone's being cared for at home, but their loved one wants to go to a wedding or have a little bit of break, that patient can be admitted to a dedicated hospice, a nursing home, sometimes even a hospital for respite through that hospice organization. And then continuous hospice can be a 24-hour service at home, but really is meant to be at a time of crisis or active dying, and where a nurse is kind of physically present to help manage those symptoms. Certainly there are barriers to hospice care, including patients who continue to have a preference for disease-directed treatments and have oncologists who are partnering with them to provide those treatments. Challenges with prognostication, which I think is perhaps a more theoretical barrier, again, because physicians don't have to promise how long someone's going to live, and patients can, depending on how they're feeling, leave hospice. Inadequate caregiving can certainly be a barrier because hospice doesn't provide that 24/7 support. And we run into this every day on the consult service, the palliative care consult service in the hospital. Hospice doesn't pay for room and board in nursing homes or assisted living facilities. So essentially will provide the equivalent of home-based care, but requires patients to have a source for room and board. Another barrier, or I would say disparity, are differences in hospice utilization associated with race and ethnicity. So, essentially, hospice is primarily a service for white patients. It's certainly not designed that way, but if you look at African Americans, their utilization is overall less than, and this is North Carolina data, the population in this state, and then it's virtually zero for Latinos or for patients from Asian backgrounds. And that's not just in North Carolina, that's a challenge throughout our country. Let's see. One of the things, in terms of how to address hospice concerns, at least from my approach that I would recommend, is asking about experiences with loved ones and friends. Many are very positive, but for those that are negative, trying to tease out what some of those issues were. Was it hospice care from 30 years ago, which might have been different, or things that concerns that can be addressed? And then I think first we need to identify if comfort and dignity are the primary exclusive goals, and someone has identified trying to be at home, then I feel comfortable recommending hospice as a service that is not all things to all people, but can be very effective in supporting those goals. And so I emphasize that it can help focus on, as I said before, making every day the best day possible, maximizing quality of life, and again, emphasizing it's not an end-of-life program so much as living well until death occurs. What I also do share is that services can be discontinued. I just saw a patient a few minutes ago next door in the hospital who, in the event of an acute illness, made a decision to disenroll from hospice and seek treatment in the hospital. It is not black and white in terms of not being able to change your mind. And as well, noting some of those challenges with prognostication. What we also know, in a very positive sense, is that hospice has been associated with improved outcomes. Quality of care, quality of the dying process, increased symptom management, decreased use of interventions that have limiting benefits for patients with advanced illness, whether they are tube feeds or the hospital. Increased consistency between where someone wants to die and where they actually die. And from prior data, there's no change in survival associated with hospice. Again, patients link, well, that person received hospice services and died, but it's not a causal effect. So here's a graph from a snapshot of the last 15 years or so about where patients are dying. And I would emphasize that I think in part because of hospice, from 1999 to 2015, and this is the green part of the slide, more patients are dying at home. I mentioned, and this is the bottom, I think it's red, more patients, inpatient hospice didn't exist 20 years ago. Now it's almost 200,000 patients who died in an inpatient hospice facility. But still the vast majority of patients are dying in hospitals, more than 1 million. What's their experience like? And that's where the question is, well, why isn't hospice enough as an end-of-life care program? And so 20 plus years ago, there was a very critical study based in 5 teaching hospitals in the United States, looking at almost 10,000 adults in the hospital with 9 diagnoses that gave them a 50% 6-month mortality rate. Advanced heart disease, advanced cancer, liver, lung disease. And what we learned from that study, kind of from a population sense, is half the patients had moderate to severe pain prior to death. A third of patients were dying in the ICU. Only half of the physicians knew when their patients wanted to be allowed a natural death. And when those orders were written, it was almost like last rites occurring very close to death. And they developed, as part of this study, an intervention where nurses gave physicians information about patient prognosis, had no impact. And so again, if we're not getting people home with hospice, they're dying in the hospital, that was kind of historically what led to the field of palliative care being created, and it didn't exist when I was a medical student. And this is what I remember in my training. There was disease-directed care, where the goal was cure, and then almost on a dime, people would transition to end-of-life care if we had enough time in the hospital or occasionally with hospice. But that's fortunately not the model that exists in 2017, which is, if you look again at that rectangle, from diagnosis to time of death, palliative care increasingly is integrated with disease-directed therapies. So it may undulate a little bit in terms of patients who are going through chemotherapy may have times where they have more need for emotional or physical support, and then times where that recedes as an issue. And it's not a fixed point where people start getting palliative care. It can exist from the time of diagnosis. And so what we try to emphasize with patients is it's specialized medical and healthcare. It focuses on improved quality of life, and I'll share the data shortly. Really, for patients with any diagnosis, it emphasizes relief of symptoms, stress, and for some that helps make disease treatment more possible. It's provided not just by physicians but by a team, and that we work together as an added extra layer of support. And again, we coexist with treatment intended for cure, with treatment intended to prolong life. We are not care at the end of life. And another way of thinking about it is there's comfort care represented by that yellow circle that's very limited, kind of in the hospital. There's a larger sphere of care, which is hospice care, and then much broader is palliative, or what some call supportive care for individuals with cancer. And then symptom management, which can be anesthesia, which can be other addressing other care needs, may not even be related, it doesn't have to be someone with a life-limiting illness. And so if you compare and contrast hospice and palliative care, the pain and symptom management can be similar, the patient and family support, hopefully robust, addressing patients' communication needs. Where some of the logistical changes are or differences are, hospice is a defined insurance benefit, is pretty comprehensive. Palliative care, I wish it were different, but is more limited and primarily focuses on physician consultation, often relies on hospitals, health systems for additional support of teams. There is that prognostic difference that I mentioned with hospice. For palliative care, we can see people truly independent of prognosis. The goals can be different, where hospice is exclusively geared towards comfort and often avoiding hospitalizations. In palliative care, we can be in the intensive care unit, anywhere in the hospital, coexisting with those care interventions. And then in terms of where it's happening, I mentioned that hospice primarily is a home-based program, although can be provided in long-term care and inpatient facilities. Palliative care is actually changing. It was born out of hospitals, as I shared, from 20 years ago, but really the wave now is to provide that service in outpatient clinics, at home, in long-term care facilities, to get our palliative care upstream. And this is where we are in terms of, again, over the last, and this is a little bit dated in terms of the last year is 2009, but by then, virtually all hospitals over 300 beds had an identified palliative care program. Now, that doesn't mean 24/7 care or necessarily what the team looked like, but identified as having a program, 2/3 of all hospitals. Interestingly, not equal among the states, and so where we are in North Carolina, we're kind of graded as a B by one of the national palliative care organizations. I think we have about 60 to 80% of hospitals with more than 50 beds have a program. Be interested from our audience whether their hospital, what kind of program they have. Certain areas of the country, Pacific Northwest, New England, virtually 100%. So, and then in the Deep South, there can be few hospitals with programs. Just to give you a sense, here in Chapel Hill, we have a hospital consult service. We have in our cancer hospital a clinic, dedicated clinic, and then in the Triangle itself, UNC has opened a few months ago an inpatient hospice facility in Pittsboro and Chatham County, and we have a program called REACH that provides home-based palliative care services. And I would imagine that wherever you are in the state, there are organizations that are starting or are thinking about starting certainly community-based palliative care programs. One of the barriers that we have is that patients and families aren't knowledgeable. So here was a study done a few years ago where 70% said they weren't at all knowledgeable about what palliative care is. And so I certainly get a quizzical look, sometimes a deer in the headlights look when I go into a room and say, I'm from the palliative care program. And sometimes we have to deal with, isn't that hospice? Isn't that end-of-life care? And so what I say when I'm meeting someone, whether it's in the clinic or the hospital, is this is what we do. We provide symptom assessment and management. We try to help maximize support that's helpful for patients and families. Emotional coping, or I feel fortunate to be practicing at UNC where there's a lot of practical support in terms of financial challenges that patients have that affect their ability to receive cancer care. We also emphasize, depending on the patient, depending on where they are in their illness trajectory, communication and decision making can relate to what they understand about their illness, what their needs are for advanced care planning, who would be their preferred decision maker, their healthcare power of attorney, and then what are their goals, and to try to make sure that we align the care that they're getting, the decisions affecting them, with what's, as much as we understand it, achievable in terms of what they're seeking. And so I would ask that palliative care gets considered for any patient with serious illness, certainly with cancer, who are frequently being admitted to the hospital or critically ill in the intensive care unit, patients who have progressive cancer that's considered incurable, even if they are receiving disease-directed treatments. And again, the world of immunotherapy that I'm actively learning more about is ongoing treatment, may impact prognosis, but as best as I understand it, for many, is not going to change the nature of their cancer in terms of whether it can be cured. And then cancer that is complicated or compounded by frailty and other comorbid conditions. And so one question that I sometimes think of that can be considered is, would that patient's death surprise me in the next year? If it doesn't, then maybe there's a role for specialty palliative care. And so what I ask my colleagues when introducing palliative care is to not ask them if they want to see us, because we don't do that with other specialties. We don't ask patients and families, do they want to see a cardiologist? We tell them that we've identified a need or a question, and this is what we'd recommend. And I would say state the indication for the referral: symptom relief, quality of life, extra layer of support, things that when I share with patients, whatever doubts they have, almost universally they say, okay, that makes sense. And again, that we are here to integrate with the primary team. We're not taking over any part of their care. So primary versus specialty palliative care, just briefly, there are challenges in terms of the demand for the services now far exceeds the supply, and that we don't want to replace, nor could we, the primary care physician, and we also don't want to be another cook in the kitchen. So there are some challenges in terms of our involvement. So what primary palliative care skills are, and that applies to anyone who's caring for patients with cancer, includes what I would call foundational symptom assessment, communication skills, advanced care planning. And then the specialty services are for more complex and difficult cases: refractory symptoms, multiple symptoms, pain crises, or when there are clear conflicts, challenges with decision making. And so it can be blurry where primary palliative care interface, and may depend on the individual health professional. And so here's another way of thinking about it, where all clinicians, health professionals, are practicing palliative care, hopefully with as much skill as possible. Secondary palliative care, I would say, are nurse navigators, oncologists, who are certainly routinely seeing patients with cancer who have serious illness. And then our role is to integrate with that specialty palliative care for some of the more complex situations. And what we know in terms of quality of care and outcome, and this is a big picture slide, and then I have a few specific trials to discuss, is I feel fortunate that I'm now in a field where there are more than 10 randomized trials looking at palliative care and its outcomes, both in the outpatient and hospital setting. And for patients with advanced cancer, and now I can say not just solid tumor, but with hematologic malignancies, particularly transplant, there are benefits across these trials. The clearest one is within quality of life, and the kind of dose effect can be as short as 2 weeks, can be kind of 24 weeks in terms of the studies that have been done. Reduced is depression, can improve other symptoms, can increase care satisfaction. That's in multiple of those 10 trials. And at least in one trial, and I think the next slide addresses this, the potential for improved survival actually, decreased use of disease-directed treatments close to the time of death when the burdens clearly can outweigh the benefits, longer hospice enrollment, improved communication about prognosis, and even end-of-life wishes. And as best as we understand it, similar to hospice, our involvement doesn't increase anxiety, doesn't shorten life, does not have adverse outcomes. So to look at a couple of studies, one actually thinking about the hospital, 3 randomized trials looking at impact of palliative care in the hospital, and there was improved communication, improved documentation of advanced care planning preferences, improved family satisfaction of care, and the earlier the better. So actually at UNC we track for the hospital when we're seeing people because we're much more impactful on day 1 or 2 than day 22. Reduced ICU admissions, and again, no change in survival. In the outpatient setting, this is the kind of landmark study by Jennifer Temmel, who's a thoracic oncologist at Mass General, who looked at, in a randomized fashion, patients with metastatic lung cancer who either received palliative care in the outpatient setting from the time of diagnosis or standard of care. And so what she designed the study to look at showed improved quality of life, reduced depression, reduced what she defined as aggressiveness of care, so less chemotherapy within the last 2 weeks of life, fewer patients who never got hospice care, or fewer patients enrolled even 3 days before death. What got this study in the New England Journal, though, was that there was an almost 3-month survival benefit. And maybe in the question and answer we can talk a little bit more about that. I certainly am not proposing that that's a clear benefit of palliative care, but we certainly don't shorten life, and we have that potential even to prolong life. And then finally, a study that was published last year looked at the impact of specialty palliative care on patients receiving hematopoietic stem cell transplants. And just to give you a sense, these were patients in the hospital, mean of 20 days, ranging from a few weeks to 100 days. And in terms of the dose effect of palliative care, in those first 2 weeks, the median number of visits for patients were 4 palliative care visits. The range was 2 to 7. So these patients weren't necessarily being seen every day by palliative care. It was sort of every other day or every few days. And with that kind of dose effect, 2 weeks post-transplant, the patients in the intervention group who received palliative care had a smaller decrease in their quality of life than those who didn't receive palliative care. So with stem cell transplant, with how rigorous it is, everyone had a decrease, but it was less for those who received palliative care. They also had less anxiety and less symptom burden and depression compared to those who didn't receive palliative care. And in 3 months post-transplant, that benefit persisted in terms of quality of care. It was higher among those who had received palliative care services in the hospital. And to kind of give you a sense, and this kind of tracks often what we do, if that initial visit, 100% rapport building. Who are we? Can we develop a relationship? Virtually all receive symptom assessment and management input. Virtually all assistance with coping. But again, importantly, I think some people think palliative care, again, we're about end of life, we're about trying to get people to make difficult decisions. Well, these were patients who had committed to stem cell transplant, so understandably it was a clear minority where patients were talking about treatment decision making. That had already been made. I might make a case that there could have been more of a role for illness understanding, but I think, again, initially the focus was on rapport building and symptoms. And the bottom of the slide shows, again, for these patients, nausea, pain, GI issues, and to a lesser extent fatigue were addressed. And because of these 10 trials, just go back, the American Society of Clinical Oncology published a guideline last year looking at these studies and making the case to say that inpatients and outpatients with advanced cancer should receive dedicated palliative care services, ideally early in the disease course, concurrent with cancer treatment. It's not an or situation, either disease treatment or palliative care. It's both. And that referral to interdisciplinary teams is optimal, but again, depending on supply, may not be possible for every individual patient. So finally, in summary, hospice and palliative care are clearly interrelated, but yet distinct, that there is a need to promote palliative care skills for all professionals. This is not limited to specialists in the field, but that for those with cancer and other serious illness, the specialty palliative care has been demonstrated to improve quality of life, decrease symptom burden, and also reduce the risk of burdensome interventions to these individuals towards the end of life. Thank you.
Dr. Winzelberg, thank you so much. Let me just remind our audience that you can go ahead and use that Poll Everywhere link now and go ahead and let us know what questions you have for Dr. Winzelberg. So again, you just text, if you haven't already done it, to the number 22333, the letters UNCCN, and then you can go ahead and start sharing your questions. So I'll start with one or two while we wait for our audience to share questions with you. Back, I think towards the end of 2015, there was a JAMA study, and it talked about, among other things, how the majority of us say we want hospice care, and yet only between two-thirds two-thirds to three-fourths of us actually die in the hospital. Where's what happens? You know, I imagine when I die, I want to be at home with my family, with my dogs, and yet chances are, 2 and 3 to 3 and 4 that I'll die in the hospital. What happens, and what's the disconnect?
Yeah, and I would say, Tim, I think if I'm remembering the study, it was more kind of preferred place of death. So people don't necessarily identify hospice, but they say they would want to live at home, and I think some of it is the people aren't enrolled, so there's that issue of receiving disease-directed treatment limits the ability to access hospice services. Some is just the nature of when symptoms occur acutely, it can be challenging to manage them at home, so that can be an issue. And then I think I'll kind of put those out as a couple of those possibilities, but I think another piece that gets to the communication is, and some patients come to mind even from the last few days, is we sometimes don't ask people. So they may say in a study what their preferences are, but we're not asking them as their disease is progressing, are we continuing to treat them in a way that meets their needs or satisfies what their goals are. So some patients are waiting for oncologists, are waiting for us to kind of have this discussion, have this conversation, and if we don't, it risks them ending up continuing to receive and potentially die in the hospital.
Just missing that question, and that another part of that study was actually talking about that healthcare providers utilize hospice at a greater rate than their patients.
Oh, that's right. Okay.
Yeah.
Physicians. Yeah. And that's the thing, right? So, and there are lots of issues, and progress is being made, but with physician and other health professional communication skills.
All right. Well, our audience is really active here. We've got a lot of questions. We'll jump right in. How many patients do you see annually at UNC, and how do clinicians know to refer them to your team?
Okay. So programs in general, I think, have different approaches at UNC, and this is actually on my mind since I'm preparing some materials about our fellowship. We are estimating about 1,100 new consults at UNC hospitals, and that's the 800 beds, not just at the cancer hospital. What I would say on the outpatient setting is the team, which I recently joined, Lineberger had over 2,000 visits last year. So there's, again, both an inpatient and outpatient program. Currently, it is in the hospital a consult referral just like any other medical specialty. So it requires a physician to essentially call us and request a consult. It's not possible for individual patients and families to request it, although in my experience, some of the consults we get from physicians are because patients and families request it. And then the physician says, oh, that's not a bad idea, and they call us. So that's generally how referrals are. On the outpatient setting, we want to partner with the oncologist. So if the referral comes from another source, we want to make sure that that oncologist is on board, because when it comes to symptom management, some of the other services we provide, we want to be integrating our care with their service.
Great. Do providers specifically educate the patient about palliative care?
The providers. Well, we certainly do in our consults. As I said from the beginning, my goal for my colleagues is to, when it's being introduced, to, again, not ask their permission, but to let them know we're coming, let them know the reason potentially, but that's the approach that we suggest.
Okay, thank you. Let's see, another one. Can certain components of palliative care be provided through telemedicine?
Yeah.
If yes, what are those components? I'm certainly interested in this
as
well.
That's a fascinating question. So our fellowship partners with an organization called Transitions Life Care, which is based in Raleigh, although is involved in 7 counties around the Triangle. They just received a significant grant from the Duke Endowment to develop a telehealth program for children and palliative care, because the area that they serve is so vast that it's just not feasible to get staff into children's homes. And so though it's not something that I practice, that program just started, and I think we'll learn from it. And I certainly can envision there being a role for that, because currently a lot of hospice care is provided over the phone. Families are educated during each nursing visit, they have medications available, but when they're calling, it's not feasible or kind of medically indicated for a nurse to always go out. And so some of it is coaching over the phone. Telemedicine would, I think, promote the quality of that communication.
Great. Let's see, another one. Suggestions for family members who are supporting the idea, but the patient is resistant to the idea of either, I'm not sure if this is palliative care or hospice. And
it absolutely can be both. I think some of it is trying to understand, and this is a easy answer or a quick answer to a challenging question, is exploring those sources of resistance and trying to get at, and it's often emotions, it's not information, it's emotions that are involved in conflict or involved in what this individual described as resistance. So whether it's fear, whether it's worry about what will happen when they're home, there may be things that we can identify that, if discussed, may or may not help address some of those concerns.
Okay, thank you. Are you aware of specific payer sources that include palliative care benefits?
What I can say about that is certainly the physician visit is covered, although certainly in the hospital setting, most programs depend on hospital or health system support given the time required, as well as the fact that we have multiple team members to practice the quality of care of an interdisciplinary team. What I also understand, and colleagues of mine are involved at UNC for trying to improve care for vulnerable patients, is that I think private insurance companies are, if not already, moving towards having this as a more definable benefit. So again, as community-based programs develop, I think, and I'm not a particular expert in this, that's something that will, similar to hospice, be more identified as a benefit.
Okay, thank you. We're going to take one more, and then there are a few really important things that I hope everyone stays for that I want to go over with our new learning management portal. So the next two are, I think, one person's question combined, and I might even add a little to that. I'm interested in your thoughts regarding assisted dying. Do you think it's more humane than a slow, painful death? And I might kind of add in there, what's the intersect between assisted dying and palliative or hospice care?
Yeah. In how many minutes do I have?
Yeah, sorry, about one.
What I would say, and this reflects my kind of professional beliefs, but clearly in a state where assisted dying or physician-assisted suicide is not legal, is that from the experiences in Oregon, in Washington, and actually I recently heard a talk from someone at UNC who's doing research in Vermont, that there is a small percentage of individuals who experience suffering, kind of existential, what we call total pain, that can't be reached by even our best palliative care and hospice, that are served by the option of assisted dying. Some don't choose it even if they receive the prescription, and some do. And so I would be cautious about sort of how that question is asked, in the sense of, I think it is rare that patients, we are able to manage symptoms intensively, aggressively when they arrive. And so physician-assisted dying, at least in the experience of the other states, tends to be a choice that people make where traditional medications don't reach when there's that degree of suffering. But is an extremely important topic. There are others, including voluntarily stopping eating and drinking, very important kind of ethical issues, and is certainly something that comes up in our communication with families. Even in a state where it's not legal, it's certainly something on people's minds, and we try to be present with them to try to understand what their thoughts are.
All right, and we'll have to stop there with the questions. I apologize because we have several more that look very good. This has been a phenomenally informative talk. Thank you so much for all the information you've shared.
Appreciate the opportunity.
I want to mention how excited we are here at the UNC Cancer Network about the Learning Portal, UNC Cancer Network Learning Portal. This is at learn.unccn.org. This is the new home for UNCCN Oncology Education Resources. So this is replacing Sakai. If you've used Sakai in the past, this is replacing some other resources. So again, learn.unccn.org. It's free, open access to 4-credit oncology courses based on recordings of our live telehealth lectures. Anytime access to earned certificates of credit for all UNCCN activities, new live lecture evaluation process. So we'll have pieces. The live lecture, as mentioned, that process, you all have been asking for this for a long time, and we're so proud to be able to bring this to you now. So anytime within a year of our 4-credit lectures, you can go on and watch these lectures. If you pass the assessment, then take an evaluation, then you can go ahead and have those certificates. You can keep them organized online. We especially want to say thank you to Alan Brown, who's just been extremely dedicated and creative in developing this for our team and our organization. The new process for completing the lecture evaluation and receiving credit, the evaluation and opportunity to claim credit for participation will remain open for 7 days. So that's for the live lecture piece. Participants at designated UNCCN viewing sites, see your site coordinator for instructions. So if you're at a site, your coordinator has already been trained on this, and she or he can provide you with the information that you need. If you're a GoToWebinar participant, you'll receive an email 1 hour after the conclusion of the lecture that contains information and a link to step-by-step instructions for completing the evaluation and claiming a certificate of credit. So again, learn.unccn.org. If you're having trouble with this, if you have questions about it, you can contact us at unccn@unc.edu or 919-445-1000. Again, Alan has done a phenomenal job with all of this, including the training and documentation. If you're experiencing trouble with any of this, reach out to us and we will help you make sure that you have everything you need from this. We have lots of great lectures still coming up in 2017. November 15th, our Med-Surg Oncology lecture, Advances in Melanoma Cancer Treatment with Dr. Francis Colicchio. Community Lunch and Learn on November 17th. Lecture on what is immunotherapy and why is it so exciting for cancer treatment with our director for the UNC Cancer Network, Dr. Thomas Shea. So we'll look forward to having him on November 17th, and then on December 6th, our RN and Allied Health series, the one you've attended today, the evidence base for integrative approaches to cancer care with Dr. Gary Asher. You can find out about all of our lectures and find the recordings at unccn.org. Finally, I want to mention we have a special lecture, Oral Cancer, a Comprehensive Overview, and I couldn't mention this without mentioning the hard work that Mary King on our team has done to conceive of this lecture and move it forward. So we've got Dr. Patel, Dr. Hackman, and Dr. Padilla will all be there for that lecture, and there will also be dental credit available, continuing dental education credit available for that. Thanks to Mary King, Veneranda Obore, Alan Brown for all the hard work that they do. Thanks to the North Carolina General Assembly for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. And thanks, Dr. Winselberg, again, we really appreciate this. And thanks to our audience. We're glad you were here today. We'll look forward to seeing you soon.
Thank you.